Start. Okay. So, as I am Dr. Agniva Basu, faculty ENT at Santiniketan Medical College. So today, as I've already heard that we have covered the topics like external ear and the anatomy of the ear. Today, I will discuss about the disorders of the middle ear. Okay. So, who will tell me the parts of the middle ear? Anatomy has already been done, right? So, someone, it has to be an interactive session, right? Someone has to come up here. So, say this is the ear. Okay, this is the pinna. And then we have the ear canal. Right? So, what are the parts of the ear canal? The bony part and the cartilaginous part. I think everyone knows that, right? So, the outer one third is cartilaginous, inner 2/3 is bony. And then we have the eardrum, the tympanic membrane. So, tympanic membrane is like this. It's a bit inclined in position. Okay. And this canal, it forms a dip like this here. Okay. So behind the eardrum, there's the TM. What we have the ossicles, right? So what are the ossicles? Everyone knows it, the malleus, incus and the stapes. Okay. So the handle of the malleus is attached to the tympanic membrane, right? So let this be the malleus. Okay. Then we have the incus. And then we have the stapes with the foot plate. So the stapes get attached to where? What is this part called? The oval window, right? So this is the oval window and we have the round window here, right? So you see these ossicles, these are contained in the space called the middle ear cavity, right? So middle ear cavity actually looks like this, a room. Okay. So there are only two main outlets. One is the Eustachian tube from the anterior inferior part of the middle ear cavity, which opens where? The nasopharynx, right? The torus tuberous, you know that. And it tells the additus to the mastoid antrum. I cannot show it in a three-dimensional way. So its mastoid antrum is posterior and this is more medial. Okay. So the disorders of the middle ear, since we are discussing that topic today, starts with problems of Eustachian tube primarily. Okay. So just consider that you are in a closed room. This Eustachian tube, the only way out, the only door out is blocked by some reason or the other. So what's going to happen? So what are the conditions that can cause this blockage of the Eustachian tube? It's most commonly in the nasopharyngeal opening. It's never in the middle ear opening. Okay? Because the flow is like this. Okay, the ciliary flow is like this. So the blockage is most commonly at the tubal opening. We call it the torus tuberis. Okay, so any infection of the nose, it can be a simple upper respiratory infection, it can be a viral infection, anything that, or it can be a tumor like a nasopharyngeal carcinoma, anything that is blocking the opening of the Eustachian tube at the nasopharyngeal end will block the function of the, or stop the function of the Eustachian tube, right? So what's going to happen next? You are in a room, the outlet is blocked, the door is blocked, so nothing in the room can go out, right? So now every part of our body has normal secretions, right? We have the mucosa, we have the cells, so there are normal secretions going on in every part of the body. So what happens is, initially the airflow, so there are two things that's moving through this eustachian tube. One is obviously the air from the nasopharynx, it maintains the pressure in the middle ear cavity, right? And second is the normal secretions of the fluid of the middle ear that is supposed to come out through the eustachian tube is not coming out. Okay, so first the air outlet is blocked, so there is no passage of air from the nasopharynx to the middle ear cavity. So what will happen? This will create a negative pressure here. Okay, so this will, so this all other parts are bony, right? So bone cannot be pulled in, so it's a hard thing. So what happens is, the eustachian tube, the tympanic membrane, it's a soft structure, it's a membranous structure, right? So because of the negative pressure here, the tympanic membrane is pulled in like this, causing a retraction of the tympanic membrane. Okay, so the most common disease of the middle ear cavity is an acute otitis media, right? Acute otitis media is an acute infection of the middle ear cavity. So like I said, it starts by the blockage of the eustachian tube. Okay, so any bacterial infection, what are the commonest causes of acute otitis media? Anyone knows? Any idea? What are the common bacteria? It's mostly a gram-positive infection, so mostly streptococcus, and it can be H. influenzae or anything like that. So a gram-positive infection causing blockage of the tube. So the first stage that comes is the stage of tubal occlusion. Okay, so what happens in the stage of tubal occlusion? When we see a patient coming in your clinic, he usually never complains of pain initially. He says that, doc, my ears are feeling blocked. I'm unable to hear properly since last one day. It's usually a very short history, these bacterial infections are very rapidly progressive infections. So they usually come with a very short history saying that, doc, my ears are blocked, do something about it. So when we look with an otoscope through the ear canal, we see that there is a retraction in the eardrum. Okay, so we assume, since it's a very short history, this might be, there is some dysfunction of the eustachian tube that is causing a retraction of the eardrum. So this can be a very early AOM or acute otitis media. We do not call it an acute suppurative otitis media anymore. Okay, we call it an acute otitis media. It's not always suppurative. Okay, so first is stage of tubal occlusion. So that we have already understood what it looks like. Okay, now then comes the stage of pre-suppuration. So the infection, so this tubal occlusion is already present. Now the infection is gradually increasing. The patient has not gone to a doctor even after feeling the blockage in the ears, but he chooses to stay back at home, feels that okay, it will recover. So now comes the bacteria continues to multiply and the infection increases. Okay, so we reach a stage called the stage of pre-suppuration. So here what happens is, so you know that if there is infection in any part of the body, the blood flow increases, right? So it's a normal response of the body. Is any part there is an infection or an inflammation, the blood flow increases. So here we see in the stage of pre-suppuration, we see that there is prominence of blood vessels over the tympanic membrane. Okay, so if the tympanic membrane looks like this, it's the right tympanic membrane. Okay, so we see that the blood vessels, it's mostly like this. It's always from periphery to the center and gives an appearance of a cartwheel. So it's called a cartwheel appearance. Okay, cartwheel means Goru Gari Chaka. Okay, so this gives an appearance of a cartwheel. So we call it a cartwheel appearance. So in this stage, the patient starts having pain. Okay, the patient starts having pain, comes to you with, oh, I'm having a bad pain in my ears. Look into it. So when you look through the otoscope, you see a congested, inflamed eardrum. Okay, but it is still not in the stage of suppuration. So there is no pus inside till now. It's still in the pre-suppuration phase. So after this, we have the stage of suppuration. That means there is formation of frank pus in the middle ear. So stage of suppuration. Here what happens is whatever secretions of the normal middle ear cavity was there, it gets infected and gives rise to pus here. So once the pus starts to collect, like I said, this is the only soft part or only pliable or malleable part of the entire middle ear cavity. So what happens is it bulges out. So there is a bulge of the tympanic membrane outside because now the middle ear pressure has increased. Okay, here the tympanic membrane bulges out. So if you, it's very you have pictures in your book anyways, so it's a very classical picture. If you see once, you will never forget. Once you see with the eardrum, it's totally congested, bulged out, and since this is more common in children, I'll come back why. Since acute otitis media is more common in children, most of the children, they do not allow examination if it's so painful. Okay, the patient stops eating, starts having fever now because it's suppurative. So there is pus, active infection going on, and the patient starts having systemic signs of inflammation. The patient may have fever, pain. Now, if the infection is so bad and the patient has come to the doctor quite late, what happens is there is a rupture of the tympanic membrane and the pus comes out. Okay, so when we see that there is discharge in the external ear. Okay, it's a purulent discharge in the external ear. So what are the features? Bulged tympanic membrane, bulged and congested tympanic membrane. Okay, there may be pus points. Sometimes it's not bulged, it's not ruptured yet, but there is a sharp nipple-like swelling here. We call it a pus point. Or there may be total rupture of the eardrum that comes out. And there is obviously severe pain and other systemic signs of inflammation. This points to diagnosis of the suppurative stage of otitis media. Now, the patient has severe pain in this stage. So now the medications are being started. or probably we have started here only, but it takes some time for it to act. So the next stage is stage of resolution or recovery. Okay, so once the pus, either the antibiotic has already worked and the infection is being controlled, or there is discharge of pus from outside and the pus is in the middle ear is drained, or you have started medications like nasal decongestants and other tablets to open this tube up so that the pus gradually gets drained from here. Whatever, some treatment has been done, or the pus has itself come out by rupturing of the eardrum. So now the patient gradually recovers. So this is the stage of resolution. So tell me, what can be the treatment of acute otitis media if a patient comes to you? Antibiotics, okay. So you are doing pharmacology as well, right? You are studying pharma as well, right? So what antibiotics do you think would work here? Just go for it. Tell me something. Very, very good. So we are considering a gram-positive infection. So we need an antibiotic that has a gram-positive coverage. Okay, so amoxicillin or ampicillin are the best choice or the first choice of antibiotics for acute otitis media. Okay, so does antibiotics solve the problem only, or is there something else that you need to take care of? Think about it, see the picture, think about it. Where the problem starts. Drainage of the pus. Okay, it's an invasive procedure, we'll come later. First, let us talk about the medications, okay? So what is the first problem? Eustachian tube blockage. So what do we need to do about it? Nasal decongestants, very, very important. So for acute otitis media, we need to start on nasal decongestant drops, okay? So normally, nowadays we use something like a xylometazoline and oxymetazoline, which is a nasal decongestant which opens up the Eustachian tube. So the swelling or the edema around the torus tuberis, which is causing the blockage of the Eustachian tube, we need to decongest that area and the tube opens up. So gradually the pain is relieved. So when I was a kid, once I was on a vacation with my parents, I had a very bad ear pain. So my mom is not a doctor, but she started on nasal drops. I never realized why it relieved my pain until later when I was studying ENT. From 20 years later, I think. Okay, so that's true. So sometimes we don't even need to start antibiotics if the patient comes very early in the stage of tubal occlusion. Okay, this second thing done. Third, what are the other symptoms that the patient is having? Jode. Fever, pain. So we need to prescribe painkillers and antipyretics, right? So NSAIDs maybe. So we prescribe paracetamol. Okay, sometimes the pain is so severe that we have to go for higher NSAIDs like diclofenac and other medications. Okay, and another very important medication that we always use in case of acute otitis media or any middle ear infection is use of antihistamines. Okay, so antihistamines decreases the secretions in the middle ear and also helps in clearing the nose. So there is decreased collection of fluid in the middle ear. Okay, so the symptoms are a bit relieved. So nowadays, it's not mentioned probably in your books, I don't know. Nowadays there are other few medications that we use. We use some mucolytics as well along with, because it relieves the feeling of blockage very fast. Okay, so we use something like N-acetylcysteine also nowadays. Along with all the other medications that we have mentioned. So this was acute otitis media treated. So now there may be some patients who will not end up with a doctor. right? So there is another stage, it's called the stage of complications, where the patient has not come to you. Okay? So what will happen? What are the complications that can happen? Where can the infection go from this middle ear space? Look at the picture and tell me. So this is the mastoid cavity, right? So from the middle ear, the infection can travel to the mastoid cavity, causing mastoiditis. So it's an open way. It's open door. There is no blockage there. First. Second is it can go into the inner ear, causing vestibulitis, labyrinthitis, and this kind of inflammations, right? Or so there is another structure in the medial wall of the middle ear. It runs like this, facial nerve. So if there is a dehiscence in the canal, facial canal, so this pus can cause compression of the facial nerve and can cause temporary facial paralysis. Okay, it's more common in children, though adults we don't see much, but it's a very, very disturbing complication of acute otitis media. I know people, I have patients who, whenever they have ear pain, they have facial paralysis. They have that like 10 times in their life already, but you cannot do anything about it. Okay, you cannot tell them to use medications forever and ever, right? But they must have a dehiscent facial canal, so that whenever there is any mild infection of the ear also, they will end up having a facial paralysis. Okay. Another known and dreaded complication of acute otitis media is acute petrositis. Okay, when the pus travels towards the petrous apex, it can cause an acute petrositis. Okay, so these are the basics of acute otitis media. And someone told me about drainage of pus, right? So when do we do it? What's it called? There's a medical term for it. Syringing is something different. Don't utter this word in front of the examiner. Syringing is something that we do when there is something in the external ear. Okay, here we are draining pus from the middle ear. I have done it myself. It's an OPD procedure. It's rarely done. It's very, very rarely now, because nowadays we have very good antibiotics, and most of the times when we start antibiotics, the symptoms are usually relieved and the patient is relieved. But rarely we may need to do this kind of procedure. It's called a tympanocentesis. Okay, so sometimes we need to put some local anesthesia on the eardrum, put a needle through it, and withdraw the pus from the middle ear to relieve the middle ear pressure and relieve the pain. Okay, so there is another entity called otitis media with effusion, right? See, all this started here. Like, if everything has started here and ended here, no infection, just the tubal occlusion, and the infection, there is no infection, there is some reason for the tube to get occluded, a non-infectious cause obviously. Maybe a child is having an enlarged adenoid that is blocking the Eustachian tube opening, or maybe having an nasopharyngeal mass that is obstructing the Eustachian tube opening. Okay, something or the other is there, it's blocking the Eustachian tube, but there is no infection. So the disease starts and ends here. This is something we call the serous otitis media or otitis media with effusion. The patient only has one complaint: blockage and fullness of the ear. And obviously associated with it, the patient will have some decrease in hearing. there will be some decrease in hearing obviously, because there is fluid in the mid layer. So this initially there was some retraction of the TM, but this blockage continued and there was secretion in the mid layer. It's not pus, it is clear secretion of the mid layer. Okay, so when we see through the otoscope, it's very classical. If you see some pictures, you'll definitely understand this. There are pictures in your book. We see air bubbles. Okay, the air fluid levels in the mid layer, and you can clearly appreciate when you tell the patient to do Valsalva. You know what a Valsalva is? Okay, so blocking the nose, you try to force air through the Eustachian tube into the ears. So when the air enters, so these bubbles move around. It's very classical. So these patients have only like two complaints, like I said. One is blockage sensation and decreased hearing. No other complaints. Okay, but this is how the patients present. So these are most common in kids. So the mother will come to you, will tell you that his teacher is saying that he is not able to hear properly in the class. So whenever he is sitting in the front bench, he is perfectly fine. He is answering to all questions and all good. But whenever he is sitting in some back benches, he is not hearing properly. He is not reciprocating, he is inattentive in the class. So when we look into the ears, we find that the eardrum is bulged with fluids and the patient is having something like a glue ear. So what is a glue ear? So if you keep fluid anywhere enclosed in the cavity inside your body, what happens is gradually there is thickening of the fluid. The fluid thickens and forms something like a sticky glue. And that glue is not easily drained through the Eustachian tube. Okay? But it causes significant tamponade effect. So it causes decrease in the conduction of sound through the mid layer. And obviously the patient cannot hear properly. The kids usually do not complain. They're not even aware of it. But the mother complains that the kid is not attentive in his class, in his or her class. So, what is the treatment for serous otitis media? I have explained the causes. You will tell me the treatment. No? Jodi, I cannot hear anything. Stand up, tell me. I cannot lip read from this far. Someone has to come up. Why? So like I said, we start with nasal decongestants to open the Eustachian tube. Okay. For the kids, we usually use half the dose. It's 0.05% xylometazoline. And the kids obviously cannot do a Valsalva. You cannot tell a kid to do a Valsalva. They won't do it. Right. So we start with nasal decongestant and antihistamines to clear up the nose. And we definitely examine the kid properly to find out what is the cause of the serous otitis media. So why is the tube getting blocked? So we investigate or we examine properly the upper airway. So most of the times the patient will have an enlarged adenoid. So adenoid tissue in the nasopharynx will cause blockage of the Eustachian tube opening and cause this fluid collection in the mid layer. Okay, so it's very common. It's very common. So what we do for these patients? A serous otitis media patient, you have started on medications, but the patient is not responding. He is still having same problems. His mom is coming 2 to 3 times in a month and telling you, doc, is not improving. He is having the same problems. So because the fluid has already been converted into something like a glue, like I said, it's not coming out through the Eustachian tube even after your medications. The Eustachian tube probably has opened already, but since it is thickened, it's gluey, it's not coming out. So we need to intervene surgically here. Okay, so what we do? We make an artificial hole in the eardrum and put a tube. What is this called? What is this called? It's called a grommet. Have you heard of the name grommet? A grommet is a tube that connects the external ear with the middle ear cavity. Okay, so we take the patient to the theater, put the kid under anesthesia, and then we put a small nick on the tympanic membrane in the anterior-inferior quadrant, because behind the posterior-inferior quadrant we have the round window. Okay, so if we cause a nick and put a tube over there, there will be loss of the tamponade effect, and the patient will not be able to hear properly. Okay, so we do it in the, sorry, this is the other way around. We do it in the anterior-inferior quadrant. We put a small nick and introduce a tube through it and keep the tube in place. So it has two flanges and one tube. So once the inner flanges go in, the tube gets stuck in there. Okay, so this creates an artificial connection between the external and the middle ear cavity through the tympanic membrane. So now you'll ask me what happens to the tube after that. So once its connection is established, there is free ventilation of the middle ear through this tube. Gradually, the patient recovers from the serous otitis media over time. Okay, and once the job is done, this tube is usually pushed out by the body itself, and there is gradual healing of the artificial perforation that we created. It's a natural process. Okay, so if the examiner asks you, how will you remove a grommet? Say most of the time, sir, it's removed automatically by the body. It usually is pushed out into the ear canal, and the eardrum perforation that is made is usually heals by itself, because once it comes out, the middle ear pressure is equalized and there is no infection per se, so the TM will automatically start healing. So once it starts healing, it pushes the grommet out. Okay, so and another important thing is, since we were looking at the causes, we'll need to rule or take care of the causes that is causing the Eustachian tube blockage. So like I told you, common causes are enlarged adenoids. So we may need to do an adenoidectomy in these patients. So we normally, for investigating this otitis media with effusion patients, we order a X-ray nasopharynx lateral view to see the adenoids. You will have those X-rays in your exams as well, so you'll get to see those X-rays later on. You are part 1, right? Yeah, you'll get to see those X-rays later on when you are doing your ENT clinics. You'll see. So we order one X-ray of the nasopharynx lateral view, and it typically looks like this. Say this is the nose, this is the palate, and this is the skull base coming in here. It typically shows enlarged soft tissue over here. It is the adenoids. Okay, so we do surgeries to remove the adenoids and clear all the adenoid tissue around the torus tuberis, around the Eustachian tube opening, so that the tube doesn't get blocked. Okay, so this is mostly all about your acute infections. Another entity, there is an acute necrotizing otitis media. So it's a very, very severe infection. It's a very severe infection, virulent organism. It may be a pseudomonas or it may be a very virulent organism causing extensive destruction of the structures of the middle ear. We normally do not see this in case of acute otitis media. we see this kind of destruction of the middle ear structures in chronic otitis media in unsafe variety or the squamosal variety. But we do not see these things in acute otitis media except if the infection is pathogen is very virulent and causes massive infection and necrosis of the middle ear structures. So it can cause, like I said, it can directly very fast go to the stage of complications, because since the pathogen is very virulent, the time that the antibiotics take to control the pathogen is usually longer than its than the virulence that the organism has. So it will cause destruction of, so that it will initially cause a big perforation of the eardrum, it will cause destruction of the ossicles, it may erode the facial canal causing a facial paralysis, it may dangerously cause labyrinthitis, vestibulitis very early, and when you see through the eardrum, when you do an otoscopic examination, you will see debris. So you will find gross debris in the middle ear cavity. All the signs of acute infection, including the systemic signs like fever, pain, decreased hearing, ear discharge, and these patients usually come with ear discharge because the TM is usually perforated very soon. Okay, so once the TM is perforated, the patient will have a lot of discharge, and when you clean the discharge, you will see necrotic debris in the middle ear cavity. Okay, so there will be foul smell also, because once there is erosion of bone, there is always a very bad smell. Okay, so anything that erodes the bone will cause a bad smell in the body. Okay, so acute necrotizing otitis media will end up giving you a very bad smell. So this was mostly all about acute otitis media and the acute infections of the middle ear. So some other entities are there, right? Like recurrent otitis media. Like I said, you already know why. হ্যাঁ না কিছু তো বল বাবা, বলে দিলাম সব কিছু মোটামুটি বুঝতে পেরেছিস? Any doubts? I think I was pretty clear about the things. If you have any questions, you are always free to ask. I like it being interactive, so please interact. If you have any doubts, please clear it, because these topics will not be covered again. Okay, so we'll move on to the chronic infections. We'll start the basics of the chronic infections. I think we have only 15 more minutes, so we'll just start with the basics of the chronic infections of the middle ear. So the commonest, so what is a chronic otitis media? So media means middle ear, right? Otitis is inflammation of the ear. Chronic is chronic. So what is the difference between chronic and acute otitis media? Loud. Duration. So when do you call it a chronic otitis media? What is the timeline? More than 12 weeks. Okay. Someone else? Any other opinions? So there has been multiple schools of thought. Okay. So nowadays, if you go through your books, you'll probably not see a timeline. Previously, we used to say that it was 3 months, that is 12 weeks. He's not wrong. He's absolutely right. Some people used to say, no, it's 6 months. Okay. So there are multiple schools of thought. But now, we do not go into the details of the duration anymore. Okay. We go to the pathology of the disease, the pathogenesis. Okay. The development of the symptoms, what the symptoms are, and how the patient goes through the disease, the course of the disease. Okay, that defines whether it's a acute otitis media or a chronic otitis media. Okay, so the infection can start anyway. It can start as an acute otitis media and end up having a chronic otitis media, right? So an acute otitis media ideally should go through these phases that we have mentioned, like tubal occlusion, pre-suppuration, suppuration, healing or resolution or complications. Something like this would happen. Okay. Now the patient starts with an acute otitis media, is having in the stage of suppuration, is having ear discharge, have given medications, the pain has gone, but he keeps on having discharge off and on. So the patient had an acute otitis media, started with it, but never came out of it. Probably he have had multiple infections during this period. Okay, but the fact is he has not come out of the infection. He has probably recovered from the infection, but the tympanic membrane probably would not have healed. And in the meantime, he had another episode of infection. Right? So we are not going into timelines anymore these days. We go through the disease pathogenesis. That is very, very important. So what happens? What are the types of chronic otitis media? Loud, I cannot hear you. Loud, please. Suppurative and non-suppurative. Okay, good. So that is one way of classifying it. Suppurative otitis media and non-suppurative otitis media, or the suppurative phase and the non-suppurative phase, we call it. Okay. So whether it's an active disease or a inactive disease, that's one way of classifying it, right? And the second way of classifying it is where the problem is. So now, if you see, say this is the eardrum. So which side eardrum is this? Left or right? Right. Why? Because this is towards right. Okay. So we have two parts of the tympanic membrane, right? The pars tensa and the pars flaccida. So the pars tensa is basically it's a tense structure. The pars flaccida is pretty lax. Okay. So based on where the disease is affecting the ear, we divide a chronic otitis media into two main varieties. One is the mucosal type or the safe type of chronic otitis media. Or it's also called a tubotympanic disease. So there are three names of the same disease, same type of disease. So this is that disease that affects the pars tensa. The patient has a chronic perforation of the eardrum. That may have come from anywhere. It may have come from recurrent otitis media, or the patient had a trauma which did not heal. Okay, or patient had recurrent infections of the ear which persisted. The patient didn't take proper treatment in time, or the patient is having recurrent infections in the nose causing recurrent ear infections, but maybe subclinical. The patient didn't have much of symptoms unless he started having discharge from the ear. Okay. So when we are dealing with a mucosal variety or a safe type or a tubotympanic type of disease, we are dealing with disease of the pars tensa, where there is a perforation in the pars tensa. Okay. Why it is a safe type? Why do we call it a safe type? Because these perforations in this part of the eardrum usually does not cause major complications. Why? Think about it. And any perforation in this type, in the ear. So you know what a scutum is? What is scutum? You have gone through the anatomy, right? What is scutum? Which part of the epitympanum? What's your name? Jyotirmoy. Good, very good. Which part of the epitympanum? It's the outer bony wall of the epitympanum. Okay, like I said, when I drew a picture, you said I drew it like this, right? So this part is the scutum. Okay, so it lies behind this attic area. It lies behind this pars flaccida. Okay, so when we are having an infection in this part, so it usually rapidly can cause erosion of the ossicles lying in here. Okay, so and it is very close to the skull base, the tegment tympani, which is the roof of the medullary cavity. Okay, so these kind of disease here are more prone to cause complications, early complications. So we need to treat them fast. We cannot wait for a long time to treat this kind of infections. But when the infection is limited to the pars tensa, these patients behave very indolently. They have a very indolent course of the disease. For a very long time, they will continue having discharge off and on, off and on, off and on. And over time, they may need a surgery probably to close the eardrum most of the times. But then again, we do not rush the patient. We tell the patient, okay, you are having an infection, we'll give some medications, get the infection down, make the ear dry, and then we'll go ahead and operate on you and repair the eardrum. Okay. Now, any infection here, this part of the pars flaccida, we call it an Atticoantral disease. Okay, or an unsafe type of otitis media, or a Squamosal type. So like the three names over here, this disease also has three names. So this one is mucosal, this one is squamosal. This one is safe, this is unsafe. This is tubotympanic because, like I said, repeated infections of the ear, the patient is having perforation, so it's mostly related with the functions of the Eustachian tube and the pars tensa of the tympanic membrane. So tubotympanic type. And this part, like I said, is deal with the attic and the mastoid antrum. So this is an Atticoantral variety of the disease. Okay, I think the names are clear, right? So now we need to know what is the difference in pathology of these two parts, these two diseases. Why there are some patients who comes with a simple tubotympanic disease, and there are some patients which comes with the Atticoantral variety or the unsafe type of otitis media. Okay, so the whole pathology is completely different. There are actually two different diseases. Okay, so a stimulus or a source of infection or something that is causing a mucosal disease or a tubotympanic disease is not a kind of infection that will cause a Atticoantral disease. Okay, so the pathology is completely different. Both are types of chronic otitis media, that I agree, but it's actually, if you go through the pathology, it's completely a different pathology. The disease develops completely differently. Okay, so this unsafe type of ear or the unsafe, do we have time enough to discuss all this? I think we have only 3 minutes, so I'll just pinpoint a few important things before we'll discuss this, because this needs another separate class to discuss chronic otitis media. It's a long topic, it's an exam topic, and we'll need to talk about it in details. So the pathology is somewhat different for so you already know the pathology of the tubotympanic disease, like I told you, right? So like AOM, it starts like that, goes ahead, progresses, the perforation stays back. So whenever the patient is having a URTI, any respiratory infection or anything like that, he starts having discharge. Okay, so this is a tubotympanic variety. It's a safe variety, no major chances of complications, but sometimes due to repeated infection it can cause complications, but not very common. But when we are dealing with Atticoantral variety, the pathology is different due to some stimulus or some issues with the middle ear pressure, whatever it can be. So here say this, here lies the mastoid antrum, right? So behind the eardrum we have the adytus. Adytus is the connection between the middle ear cavity and the mastoid cavity, and we have the mastoid antrum. So if there is a negative pressure in here, so there is formation of a retraction pocket in the pars flaccida. So unlike pars tensa, see if you have say this cloth. So if this is taut and tight, you have a trauma here, it will rupture, perforate, right? But if it's soft, what will happen? It will gradually go in, right? So when we are dealing with the infection of the pars tensa, like I said, it's a taut place. This ends up in a perforation. But when we are dealing with this space, it doesn't perforate easily because it's lax. So it creates something like a retraction pocket. Okay. So it goes like this. Here, say this is the pars tensa. There is infection or some negative middle ear pressure. This causes this to go in, and form a sac, or form a pocket. So we have this pocket formation over here. So initially, when the patient comes early, when we can see an intact pars tensa, but there is a retraction pocket in the attic region. Okay, so if the infection is very early, if the entire pocket can be visualized, we can see the fundus of the sac, and we can clean the debris from there. We can keep the patient on observation, give medications, try to improve the reasons for having this kind of infection, and there are some patients who will respond and will not progress further. But if this stimulus of the negative pressure continues, what will happen? This sac will gradually increase in size, and there will be collection of debris inside. So initially, say the sac was like this, all the debris that used to collect here would come out because the mouth is wide open. But if this continues to grow and be like this, the debris that's collecting here will not come out, right? So initially it was a self-cleansing sac, and now it's not self-cleansing anymore. Okay, and there will be collection of debris in here, and these are mostly keratin debris. Here comes the concept of cholesteatoma. Okay, so we will take another class on chronic otitis media about cholesteatoma. It's very important topic. You may have long questions from there, and even in exam you may have a case of an unsafe variety. There are multiple theories of formation of cholesteatoma. We'll discuss about congenital cholesteatoma, acquired cholesteatoma, the varieties of cholesteatoma, how it affects, what is the treatment, what is the canal wall up procedure, what is the canal wall down procedure. All these things we'll discuss in details in the next class. Okay, I think it's good for today.